Thank you so much and welcome.
Thank you so much. Hi, everyone. I'm Tessa. I'm a physical therapist at Emory Decatur Hospital, and I am really excited to be here with you guys today. Feel free if you have questions while I'm going through to raise your hand with the little emoji thing at the bottom, and I'll try to keep an eye out for that and answer any questions, but I'm sure there'll be time at the end as well. And just so I have a general idea of the time that I have to talk, is it about 20 minutes or 50, how much time?
You've got until 2 o'clock.
Okay.
So you got time for a presentation and some questions and discussion.
All right, great, excellent. Thank you, Victoria. So my area of focus is primarily pelvic health, which means anything to do with the bladder, the bowel, the abdomen, low back, pelvis itself. I do pregnancy and postpartum, incontinence issues, and that's what I'm going to talk about today, is incontinence and what that is, what physical therapy can do for that. A lot of people, I didn't even know until I became a physical therapist that physical therapy could address urinary incontinence, bowel issues, but it can do a lot for that. And so my goal is to just give you sort of an introduction to the different types of incontinence issues that people can have throughout their life, and the beginning of a few different kind of exercises one could do at home to address that, and sort of the big picture of what causes it and why does physical therapy help with that. So let's get started. So, incontinence has different causes. So there's the two primary types of urinary incontinence. So that's leaking urine, and you might leak urine when you're aware of it, and you can feel it leaking out, and you may also have leaking that you're not aware of. The two main types are stress urinary incontinence, which is when you cough or you sneeze or you laugh really hard or you do aerobics, and that physical stress on the bladder causes some urine to come out. And it might be a little bit, or it might cause the bladder to empty, but that's stress incontinence. That's one of the main types of incontinence. And then the other primary type of incontinence is urge incontinence. So that's incontinence where you're fine, and then when you have a strong urge, like you really feel like you have to pee, then you leak. So before you get to the bathroom, get your pants, down, the leaking occurs. There's also functional incontinence, which is you just physically it takes time to get to the bathroom. And so because of weakness elsewhere in the body, like in the legs or slow walking, it's more challenging to get to the bathroom on time. And so we're going to primarily talk about stress incontinence and urge incontinence today, because functional incontinence, the best treatment for that is getting stronger, more mobile, setting yourself up so you're close to the bathroom. I'm going to try to change my view so I can see everybody. There we go. Okie dokie. So I had a few little notes of what I was going to talk about. I guess before I start going more into detail, are there any questions yet?
What if you just have an overactive bladder, like, the slightest thing like coffee or something like that? You can't drink coffee without having to go to the bathroom suddenly.
Yeah, good question.
What about an overactive bladder like that?
So that ties in with the urge incontinence. So irritation to the bladder increases the urge. It causes the wall of the bladder to activate and empty. So when I talk about urge, I'll go into more detail about overactive bladder and kind of how that ties into that. That's a really good question.
Yeah, that's what I was wondering. Thank you.
Yeah.
And I have a question.
Yeah.
About the physical therapist told me just yesterday that you don't have to have, in the state of Georgia, your doctor doesn't have to refer you, and Medicare still covers it. I could call and make an appointment.
So in the state of Georgia, it's legal for a physical therapist to have direct access to patients. up to 3 weeks or 8 visits. So it's limited. However, some places require a physician referral anyway. So I work at a hospital, a big system, so they require a doctor's referral anyway. However, a lot of smaller clinics will see patients up to either 3 weeks or 8 visits without a referral. And different states are different, but that's how it is in Georgia.
Okay, thank you.
You're welcome.
I have a question.
Yes.
What about if you leak during the night? And
So I
you,
will
you have
include that. That's a really good question. I'll talk about that
Yeah.
as well.
and leak during the day. You don't need to be stressed. You just keep on
It just kind of
leaking.
comes out. Yeah.
Yeah.
I'll talk about those as well. Good questions. Okay. All right. So let's start with stress incontinence. So stress incontinence, I mentioned, big stresses like coughing, laughing, sneezing, aerobics can cause it, but also little stresses. So literally just going from sitting to standing or walking as we get older or after, and into like a car accident or a delivery of a baby. These are different things that can change our body in a way that leads to more, you're more likely to have stress incontinence. And the stress incontinence is literally the bladder. So I'm going to get my bladder out right here. So here's my bladder. So the wall of the bladder is called the detrusor, and it's a smooth muscle, meaning that it's not just a balloon that's kind of just holding pee. It is a muscle that can squeeze, so it can tighten. And because it's smooth muscle, we do not have direct control over it. Now we do have some indirect control over it. I can talk about that in a little bit, but for now, just know that it's a balloon shape, but it's a muscle. And what happens with stress incontinence is pressure from the outside of the bladder because of movement of the body or a cough or something like that pushes on the bladder and a little bit of pee comes out or a lot of pee comes out. Usually it's a smaller amount with stress incontinence. So just walking around during the day, you may or may not even feel it happening, but when you go to the bathroom and the underwear is a little bit wet, that's still stress incontinence. So the treatment with stress incontinence is there's 2 primary things. One is support from below, and 2 is decreased pressure from above. So those are the things that you have control over. Now, as we get older, there are changes in our body that we all have, which is connective tissue, which is the tissue that holds everything together, including holds the bladder in place, can get sort of more mobile and things kind of lean and move into places they didn't move before. And that can contribute to incontinence. However, we do have control over the muscles underneath the bladder. So there's basically a hammock or a bowl shaped group of muscles called the pelvic floor. And the pelvic floor can be strengthened through certain exercises. And those exercises and the strengthening it, which takes a long time. This is not a quick intervention. It's not like you take a pill and it's suddenly better. It's something you do every day for weeks before you start to see significant changes. You might see some benefits as soon as you start doing it, but to see really big changes, you have to stick with it a long time, which is why it's really hard. And most people don't stick with it a long time because they get discouraged because they start the exercises and don't see big changes right away. So that's part of it. The other part, which is also really important, is how much pressure there is above the bladder. So a couple of things that affect that. One of them is our breathing. So every time we breathe, our lungs expand downward and create more pressure. That's good and normal. We want our lungs to expand and let air into the body. But if we're breathing really like shallow or we're holding our breath, we don't have that break where the lungs come back up as much. And so we end up having more sustained pressure on the bladder over time. So one of the interventions is breathing. And that's one of the things that I'm going to go over is a breathing technique you can do for a couple minutes a day that can help with that. So we'll talk about that at the end. I'm going to pause to see if there's any questions before I move on. Okay, so there are other ways to decrease pressure. Another way is healthy body weight. So staying active, a lot of times people find that if they're active, they're leaking pee, so they stop being active. That's not a good idea because when you stop being active, that's when balance gets worse. That's when you can gain some weight. You don't have as strong of a pelvic floor and core. So even if you leak a little bit with walking, it's still overall a good thing to do for your body, is to have, you know, gentle aerobics, walking, water aerobics. All of those keep you healthy overall, which helps the pelvic floor. Another way to decrease pressure from above the bladder is a couple times a day to get in a position that takes the bladder and puts it above all of the organs. So I'm going to get my pelvic model. Okay, so this is the front of the pelvis. If you look down into the pelvis, you can see that hammock or that bowl shape of muscles that holds everything up. And the bladder sits right here. So it's right sitting on the pelvic floor muscles like that. When you lay down, instead of all the pressure sitting right on the bladder, there's less pressure on the bladder. However, if your legs are straight, some of you may have noticed that sometimes it's not comfortable to lay flat with your legs straight. And the reason for that is it can cause a little arch in the back. This doesn't happen to everyone, but it happens to a lot of us. And that causes the pelvis to be in a position where there's still pressure on the bladder. In addition, the back doesn't feel great. So if you can lay on your back and put lots of pillows so that your legs are up high, or if you're able to get on and off the floor, you scoot your butt up to the couch and put your legs on the couch so your knees are bent and your hips are bent. This is a fabulous position for many reasons. It's good for the back. If you have any sort of swelling in your legs, it can help with that. But it also decompresses the bladder. So I have a picture of that position somewhere. So you can see her. Now, you don't have to have the legs this high up, but when they're this high up, you get more of that release for the back and the pelvic floor. So in a nutshell, decreasing the pressure above the bladder, either by laying in a certain position, by maintaining healthy body weight, or by practicing good breathing techniques, all of those are ways that you can help decrease pressure on the bladder and overall start to decrease the leakage that occurs throughout the day, or with a cough, laugh, or sneeze. The other piece of it is doing pelvic floor contractions, which at the end, when I talk about some of the things you guys can do at home, along with the breathing, I'll describe the pelvic floor contractions, because research shows that most people don't do them correctly. And that's part of the reason sometimes people come to a physical therapist, is to get assessed to see if they're actually engaging those muscles correctly. I can't tell you how many times I've assessed someone who thinks they're squeezing and they're actually pushing down, or they're squeezing totally different muscles like their butt muscles or their thigh muscles, but not doing anything with the pelvic floor muscles. So some people can really feel confident. They're like, I know when I squeeze, I'm squeezing correctly. I'm going to go into more detail about that in a little bit. So we'll go over the breathing and we'll go over the squeezes. And the other thing is that position. So laying on your back, legs up. You could even just do it for a couple minutes. You don't have to do it a long time. But if you do that once or twice a day, that can be really helpful. If you like the position, it's safe and fine to stay in that position, you know, for 10 minutes, 20 minutes. You could take a short nap in that position. But the first time you do it for a shorter period and get up and make sure your body feels okay afterwards. You never want to do something new for, 2 hours and then you get up and you can barely move. So try it out for a few minutes. If that feels good, you can try it out for 10 minutes. If that feels good, you can do longer. The longer your legs are up, if you have swelling, if that's an issue, the more that will help with the swelling. Now, this kind of brings me to the nighttime leaking. We'll talk about that a little bit. So nighttime leaking can be caused by different things. One of the things it can be caused by is swelling in the legs during the day. When you go to bed, your legs are up, your body drains that fluid, and so suddenly you have a lot of pee, and so you have to wake up or leak. So if you're finding that you're having leaking or getting up a lot at night and it's a lot of pee, it may be that you need to elevate your legs during the day a couple times for 20 minutes or so, and then make sure that you pee before, 5-10 minutes before bed. The other thing that might happen if you're peeing a lot at night is if you're drinking most of your fluids in the evening, that's a problem. So try to have, hydration is very important. Make sure you're drinking enough water, at least 8 glasses of water a day. And a lot of people don't like to do that if they're leaking, because they figure if they drink less, they'll leak less. Well, you might leak less, but you're also going to irritate the bladder and have more urge and irritation. So you want to stay hydrated. So I'd add that to your list of things that help with bladder health, is drink 8 glasses of water. Try to have most of it in the first 2/3 of the day. Okay, so nighttime peeing. So if it's a lot of pee that's happening and it's waking you up at night, elevating your legs during the day and drinking water earlier in the day and stopping, too much fluids in the evening is helpful. Another thing that can cause nighttime leaking is if the bladder is already irritated. And when I talk about urge incontinence, we'll talk about ways to help overactive bladder, irritated bladder, and urgency. So those sort of all go together. Okay, so I'm about to go on to the urgency and the overactive bladder. Any questions about what I talked about with the stress incontinence so far?
There are devices advertised on TV for incontinence. What do you think of those?
So there are so many different devices out there. I would say learning how to use devices with a trained therapist is the best way to go, because they can tell you which ones. There's so many of them. Some of them are helpful, some of them are not. A lot of the devices, like there's one called the LV, that's a pretty popular one. It may be appropriate for you or may not. It may not cause harm, but it just might not be targeting your issue, right? So some of them are going to give you feedback and coach you on whether you're squeezing correctly or not. Some of them are going to give you electrical current into the pelvic floor. Some people need the electrical current. Most people don't. So there's no way to say, oh, this device would definitely be good for everybody, because everybody's different. So probably not as clear of an answer as you'd like, but there's some really good devices for certain people that aren't great for others, and vice versa. Any other questions? Okay, let's talk about urgency. Urge incontinence, frequency, overactive bladder, that is all tied together. Okay, so let's go back to our bladder here. So in a normal, healthy bladder, as this fills, so it doesn't stay this size. When there's no pee, it gets smaller. When it's full of pee, it gets larger. As it gets larger, we get a little bit more urge. We should be able to defer that urge if we want to. But as we get older, that's a little bit harder, and that's normal. But for some people, they can't defer the urge, and they never could, or they had trouble even when, and that is one of the things we're going to talk about, is when it's okay to defer the urge. Basically, there's functional urge and there's dysfunctional urge. Functional urge is when the bladder fills, you get more urge, the bladder fills more, you have more urge. Dysfunctional urge is when the urge has nothing to do with how much pee is in the bladder. So dysfunctional urge can happen if we get trained to associate certain contexts or things in our environment with going to the bathroom. So a lot of people used to have a pattern. They get home from work, they pee. Eventually, putting the key in their front door becomes a trigger and makes them feel like they have to pee even if they didn't. Then eventually, maybe just pulling in your driveway becomes an urge or a trigger, even though the bladder's not full. So that's an example of dysfunctional urge. Also, the sound of water for a lot of people is an urge. They didn't have any urge before they heard the water, and then they hear the water and suddenly they have a strong urge. These are dysfunctional because they're not related to how much urine is in the bladder. So that is one type of dysfunctional urge. Another type of urge that's problematic is when it's due to irritation. So this ties into why it's important to drink water. If you're not getting enough water, it's going to be concentrated urine, and that is irritating to the wall of the bladder. So you're going to have urge more often. And when you pee, it's not going to be that much pee because you're emptying because it's irritated rather than full. Another thing that can cause irritation, so this would be a good list of things to kind of write down. Anything with carbonation, even carbonated water like LaCroix, that carbonation is a huge irritant for most people. Anything that has like non-food, non-natural items like artificial sweeteners, chemicals like sodas and energy drinks, all of that can be an irritant as well. Like little powders that you add to water. Some of them are not as bad. Most of them have a lot of different chemicals. If you look at those ingredients and you don't know what most of them are, chances are that could be irritating. Sugar for some people can be irritating, not for everybody. Caffeine is irritating for most people, and alcohol is irritating for most people. Coffee, even if you have decaf, can be irritating because it's acidic. So if you're a coffee drinker and you're finding that it irritates you, even if you have decaf or you know you need the caffeine, try cold brew, try different types. There's all sorts of different types of coffee out there that have lower acidity. So try different brands, different ways of brewing. You can look up that. I know I'm not a coffee drinker, but I know cold brew is often lower acidity. Some are marketed as lower acidity. So look for that. So those are generally the irritants. Also vitamins and medicines, which, we all need to take our vitamins and medicines, but if that happens, drink a lot of water, maybe have it with a meal, and it'll be less irritating. So if you know you're going to be irritated anyway, like let's say you have to have your coffee or you have to have your medicine, drink a whole glass of water first. That way, when you have to pee, it's because your bladder's full and not because it's irritated. So before you have any irritant, have a full glass of water. Okay, so that brings me to, so we've learned the difference between functional urge and dysfunctional urge. With overactive bladder, what happens is it responds more quickly to that urge. The best thing for overactive bladder is diminishing the irritants, increasing hydration, and surprisingly managing stress. So what happens when we are rushing, like if we're constantly feeling like we got to get stuff done, the nervous system shifts into a different gear. And in that gear, it's not a priority to stay continent. It's a priority to survive and rush through whatever you're doing. So you're more likely to have irritation and leakage when you're rushing or stressed out, especially if that's a common thing. So you may notice if you have to pee and then suddenly you realize there's no bathroom around and it makes you have to pee more because you're stressed that there's no bathroom around. That's part of the reason why the nervous system got kind of revved up a little bit. And just because of the way our bodies work, that often causes urge to increase. So learning how to manage stress through giving yourself reasonable expectations throughout the day, not trying to do too much, taking naps as needed, doing things that make you happy. The breathing technique that I teach you not only is good physiologically for the stress incontinence, but it also is good for regulating the nervous system. So I'm going to speed up. I'm realizing I'm going to run out of time. So we'll talk a little bit more about urge and then we'll go into the interventions. So with functional and dysfunctional urge, which causes urge incontinence, the trick with that is knowing when the urge is appropriate. And when it's appropriate, you reward it by going to the bathroom. So if you had urge, it built up, it's been at least an hour since you last peed, you've been hydrating, you go to the bathroom. And if it's from an irritant, go to the bathroom. You want to get that irritating urine out. But let's say you have urge and you just peed 30 minutes ago, and you know that, the bladder's not full, but maybe you heard sound of water, or you just started thinking about having to pee and then you got worried you had to pee, and then suddenly you can't stop thinking about that. That's dysfunctional urge. And when that happens, the best thing to do is to distract yourself with something else, maybe do a few of the breathing techniques. But in general, as you practice avoiding going to the bathroom with dysfunctional urge and only going when you know the bladder's probably full, meaning it's been at least an hour or more since you last peed, that can help rewire the nervous system. This can be really, really tricky. But if this is something that you think that would be appropriate for you, it might be worth going to see a pelvic floor therapist who can walk you through it really carefully, because you don't want to be holding in the pee all the time, right? You don't want to hold it in at the wrong time. But it's okay and safe to hold in your pee every now and then. Like, we should all be able to sit, if we're having a conversation, we want to finish the conversation first, then go pee, we should be able to hold it in. And if not, then that's something that can be worked on with pelvic floor physical therapy, just helping you learn the difference between functional and dysfunctional. And this is not an issue for everyone, but people who have overactive bladder or who just have really strong urge out of nowhere, that's where this comes in. So don't feel like this necessarily applies to you. you may, like many of you may have a functional bladder that you have the stress incontinence, but you don't have the urge issue. Okay, so let's talk about, before I talk about the interventions, any questions about the urgency, the overactive bladder, the bladder irritants? Okay.
I just have a curiosity question. I
Yeah.
remember years ago, I went to a lecture. I think it was a program by Emory, I don't know. But it was a urologist who was speaking, and it was at North DeKalb Medical Center.
Okay.
And he said that when you get up at night, you have to go to the bathroom. And gosh, I guess I was in my 40s or 50s. I didn't have any issues like this. He said it's not your bladder that wakes you up. You just wake up. You happen to wake up and then you have to pee. And I thought, nah, I just don't think that's true. I've always been curious about that.
Yeah, that's an excellent question. It depends on the person. There are a lot of my patients that, especially like postpartum, this can happen is they have to wake up because the baby's waking them up. They get in the habit of waking up and pee. And when they wake up, they're like, I might as well pee. Their body learns that's the time of day to pee, and it gets kind of integrated into their nervous system. And then when they're done, you know, waking up with the baby sleeping through the night, their body still remembers. And so in that case, they need to retrain their body not to wake up. And the way to do that is to not reward themselves with the pee. As we get older, we all have less capacity. So if you wake and you already have a strong urge, that is probably what woke you up. If you woke up and then you ask yourself, do I have to pee? And then it shows up, well, then maybe it was just, you know, most of us as we get older are going to wake up, even if we don't have pain. Sleep quality changes at like throughout the life cycle. So it could be you just woke up due to, you know, decrease like insomnia or just normal waking up. And then because, you know, we want to sleep, we're like, well, I might as well empty my bladder because I'm already awake. What that does is it trains the body to actually start having urge at that time. So if you wake up with urge, by all means, go to the bathroom. But if you wake up and you don't really have urge, then try, and then you think about it, it starts to show up and you're like, well, I might as well go. Then in that case, it might, and everyone's different, but it might be worth trying to practice going back to sleep. What was I gonna, there was something else I was gonna say about that. Yeah, the other clue is when you pee, is there a lot of pee? Is it like your normal emptying amount? If so, well, then it was appropriate to go to the bathroom. But if every time you wake up and you go to the bathroom, it's a teeny tiny amount of urine, chances are that it has more to do with the nervous system being kind of confused and telling you you have to go with that dysfunctional urge, and less to do with the quantity of urine. So you have to use those clues and sort of put the pieces of the puzzle together to figure out, you know, what's going on for you. And that's one of the things that when you see a pelvic physical therapist or a women's health physical therapist, they can help you identify what's your pattern. What are you doing well and healthy and functional, and what are you doing that might be contributing to some of the issues?
Thank you.
Yeah. Okay. So let's do the breathing first.
I have
and
a question. I
yeah.
have a question. I want to know if all this that you're saying is in writing somewhere that I can read. There's a lot of noise outside my house and I cannot follow everything. Is there something that you recommend?
Yeah. So funny you should ask. At some point in the near future, I'm going to have a website with a lot of information, but that might be a few weeks, it might be a few months. I will try to send the handout for the breathing and the pelvic. I'll try to send anything I have a handout for that's related to what I talked about. I have Beth's contact info, so I'll get it to her and she can get it to you guys. Yeah.
Thank you.
Yeah. So okay, cool.
I think Valerie's also recording.
Oh, great. That's wonderful. Did you hear that, Rebecca?
Valerie's still on. Victoria, is Valerie recording this session?
I think it says it's recording. So hopefully you guys will have access to that as well. Wonderful.
Hopefully we can send the link out to you, Rebecca. I'm going to try, okay?
Excellent. Okay, so with the breathing, there's two parts that I'm going to teach you. There's the inhale part and there's the exhale part. The inhale part is called a diaphragmatic breath. And if any of you have done yoga, you've probably done this before. The exhale part is called a resisted exhale. And it has to do with slowing down the air so it doesn't leave the body very quickly by using resistance from your lips or from your tongue or your teeth or by humming. And the first part, the diaphragmatic breath, helps with a lot of the making sure that the rest of the day you're having good breathing patterns to decrease the stress and incontinence. And the exhale, the resisted exhale, has more to do with regulating the nervous system. So it's two different techniques combined together. So I'm going to talk through it and demonstrate it. So the inhale, I usually lay down, and sometimes I'll put a weight, like a sack of rice, or I have a cat, so who likes to sit on my belly, some sort of weight on my abdomen to give me a little bit of feedback. So I'd be laying on my back with a weight right here, or just my hands. But you can also sit and do this, be in a recliner, you can stand, you can do it in any position. I often close my eyes so I can really pay attention to my body, and I take a moment to relax everything first. Most of us carry a lot of tension that we don't even realize. And the first key to this breathing technique is to let go of that tension. So I take a moment to relax my stomach and my hips, my shoulders, and just feel what my normal breathing is like. And if you guys want to do this along with me, feel free. Then I start to deepen the breath. So I breathe in a little bit more air than I normally would. Each breath, I get a little bit deeper. And you may feel the stomach, chest, and ribs open, and that's okay. It does not have to be just one spot. I want you to feel the stomach, the chest, the shoulders, everything expand. So that lets you know you're getting a full breath. Now, it does not have to be the biggest breath possible. If that's uncomfortable or causes you to cough, it doesn't have to be like that. Maybe do just a slightly deeper breath. So that's the diaphragmatic inhale. It's really simple. Just breathe a little bit deeper than you normally do, maybe a lot deeper if that's comfortable. Then with the exhale, I purse my lips. And the key is that there should be a noise with it, because that's how you know there's that resistance that we talked about. So when I breathe in, it's deep. When I breathe out, it sounds like this. Don't know if you can hear that, but there's kind of like an air blowing out of my mouth. Now, I'm not blowing it out. I'm not pushing it out. I'm just letting the exhale happen, but I'm slowing it down by narrowing my lips. I'm going to do that a couple more times. I can also do it with my teeth. Again, I'm not forcing too much extra air out than I would normally breathe out. I'm just slowing it down. The key here is using that resistance to slow it down. I can also do it with a hum. And what's nice about humming is it can give input to the vagus nerve, which again is part of the nervous system that we want, that can be sort of regulating. So if any of you have done any chanting in yoga or just chanting in general and found positive benefits, this is sort of a very simplified version of that. So you would just breathe in and hum on the way out. And you can see how much longer my exhale was because the air can't leave as fast. So those are all different techniques that you guys can try. And don't get frustrated if it's hard at first. It's usually hard at first. I've been doing this for years. I remember when I first learned, I would sometimes feel like my breath is out of control. If that happens, take a break, back to it later. Any questions about the breathing before I go on to the pelvic contractions?
How many times? How many times?
Yeah, you could do it one time. Like once you practice it, I'd say learning how to do what you want to do at least 2 to 5 minutes a day in a comfortable position in a quiet space on your own. That's going to help your body and your nervous system know how to do it. Then it's a tool that you can access in a stressful situation, like you maybe have to really pee, or you feel yourself rushing around and your body getting tight. you can do 1 or 2 breaths and you'll feel kind of your posture get better. And that's another thing that can make stress incontinence worse is tight posture, right? So that's why regulating that nervous system can be helpful for incontinence, is it helps us relax and have more fluid movements in our body. So I'd say at first, a good place to start is 2 to 5 minutes, either laying or sitting, whatever is comfortable for you, and just feeling stomach, chest, ribs expand, and then humming or letting the air out slowly through pursed lips. And just eventually you'll find that you'll be able to do slower exhales. At first, it might be hard, and that's okay. All right, so for the pelvic floor contraction, that is the contraction of these muscles right here. So a lot of times when we squeeze, we think we're sort of just tightening the hole. That is one of the things we're doing. There is a muscle that kind of closes around the hole. But also what you're doing is you're lifting that hammock up and in, creating support under your organs. Now, we don't want this muscle sucked in all day long. That causes its own set of problems. But we do want it to be strong, and we want you to be able to squeeze and relax. So when you practice these exercises, make sure you give yourself time to relax all the way. I usually say if you squeeze for 5 seconds, you want to relax for 5 seconds. If you squeeze for 10 seconds, you want to relax for 10 seconds. So let's talk about what I mean by squeezing. So the squeezing is the vaginal and rectal muscles. It's the muscles that you would use to stop the flow of urine or hold in diarrhea or hold in gas. However, a lot of times people also clench their butt when they're doing that. We don't want to clench your butt, your glutes, your butt cheeks. We don't want those tightening. We want just the muscles of the vagina and the rectum to pull up in. And that's the important piece, is that you're not using the rest of your body. You're not sucking your tummy in. You're not holding your breath. So once you've identified those muscles, you pull up and in, and then you try to hold it and breathe at the same time. That's the next step. So the first step is identifying the muscles and isolating them, so you're not clenching other muscles. And the second step is being able to hold that and breathe. If you feel very confident that you can do that, then you can work on strengthening. So holding for, some people may only be able to hold for 1 second or not even 1 second. It's just they squeeze and then it disappears. If that's the case, you squeeze, then give yourself a 10-second break. Then you squeeze and give yourself a 10-second break. As you practice that, you'll get more connected with the muscles. Then you can work to 2-second holds all the way up to 10-second holds. And then when you're doing 10-second holds, you hold for 10 seconds, relax for 10 seconds. But don't jump ahead. If you're not engaging correctly, you can actually make it a little bit worse. Like if you're pushing down or you're compensating by holding your breath, that's not helpful. So it's not helpful to squeeze for 10 seconds if you have to hold your breath. So make sure you feel very confident that you're doing it correctly before you progress through that. And that's one of the main things that I do with a lot of my patients, is I do an assessment and give them feedback about, are they actually activating the muscles correctly? If so, are they able to control them well? Can they squeeze all the way? Can they squeeze part way? Can they relax all the way? And then tell them, okay, you can do 3 seconds well, we're going to start there. Or you can only do, 1 second, we're going to start there. So that is what a pelvic floor contraction is. And not everyone needs to do them. So some people are strong there. Some people are too tight. That tends to be people who were very intense athletes who had incontinence at a young age, like in their, teens or their 20s. Those are the people whose pelvic floors are so tight that that's the issue instead of weakness. So I got to give a stipulation that not everyone needs Kegels, or I call them pelvic floor contractions, but they've often been called Kegels as well. And that leaves us 3 minutes for questions. I see a hand, Barbara. You got to unmute.
I've read 2 different theories and I don't know which one's correct. When you practice the Kegel exercise, I've heard once it's good to practice it while you are actually urinating so you can see that you're stopping the flow. And then I read somewhere else that you shouldn't be doing it while you're urinating. So which is correct?
That is an excellent question. It is okay to do that once or twice to make sure that you're stopping the flow of urine. but you do not want to get in the habit of practicing on the toilet because that rewires the nervous system and confuses it. So then you have trouble emptying appropriately. So practice once or twice, see if you can stop the flow of urine, and then remember what that feels like and don't practice on the toilet. Every month or so, if you want to practice once or twice, that's fine, but do not do a whole set of pelvic floor contractions on the toilet, and don't do it, you know, every day. And the other thing I will say is I have had patients who are able to stop their flow of urine by pushing down. So they think they're squeezing correctly, but they're actually pushing down. And they're like, well, I know I'm doing it correctly because it stops the flow. But when I assess them, they're actually pushing down and squeezing at the same time and all sorts of things that are not good. So again, stopping the flow of urine, it's a clue, but it doesn't let you know for sure that you're doing it correctly.
Okay.
How do you measure during sessions whether the patients are doing it right or wrong?
How do I assess that?
How do you measure?
Yes, how do I measure? So I do an internal assessment vaginally, but it's not a speculum exam. So at the doctor, when you've had pap smears, they use a speculum because they're doing a pap smear, they're doing an exam. I insert one finger to feel what's happening with the muscles. So I have you squeeze, I have you relax, and then I have you bear down a little bit to make sure you can stay relaxed when you bear down. Then I give you feedback. Oh, you squeezed correctly or you squeezed incorrectly. If you squeeze incorrectly, I give you some feedback, some ideas, and then I have you squeeze again and see if you do that better or worse. So that's how I assess it. There's other tools that you can, like there's a device you can insert. It's sort of like a tampon shape, and it measures the electrical output of the muscle. But that doesn't really measure the strength. It just measures, are you turning on the muscles or are you not? So there's also some crazy instruments they used to use that they would insert that could measure the force of contraction, but that is not necessary and not used in physical therapy. It's just more in a research setting that they use that. And if someone can't tolerate a vaginal exam, because some patients can't, I may feel externally to see if the pelvic floor lifts inward, to see if the opening closes and tightens. So yeah, like when I have patients that are pregnant or have a lot of pain, then I assess externally to see if I can see the changes that I want to see in the pelvic floor. And then I have some patients that have had surgeries where they no longer have an opening in the front, and we can do rectal exams or external exams for that as well. All right, any other questions? All right, I will make sure I send some of the relevant handouts to Beth, and I think she has a way to get in touch with all of you. But this was, I enjoyed this. I hope you guys learned something, and yeah. All right.
Will we be given a way to reach you or to make appointments? Will we be given that?
That's a good idea. The phone number, so the way to make appointments.
Tessa, if you just want to send me a signature line, I'll stick it in my email to these folks that showed up today.
Okay, yeah.
Beth, is that how you want to do it?
She had to get off.
Victoria, Beth had to step off.
Okay, that's fine.
I'm working with her. She had to hop into another call, but that would be fine.
Oh, there she is. Okay, perfect. All right.
Yeah, that would work.
Oh, okay. Who's that?
This is Mel Heiner. Can
Oh,
you?
hi, Mel. I thought that was you, but I wasn't sure. Glad to have you, dear. Thank you so much.
Thank you so much.
Yeah, we're grateful. All right, just send me whatever you got, and I will send it on.
The phone number now.
Okay, that's fine. Go. Well, you know what? Let's type it in the message place. Tell me the phone number.
So I'll type it and I will, so for appointments, call. So for appointments, you need a referral from your doctor. Fax to 404-501-7186. I'm putting that in the chat, and I will also include that in the email. And then the phone number. So if you have questions, you want to talk to the front desk, office phone number is.
Would you repeat it, please?
Yeah, I'll repeat all of it at the end. So this is the office phone number. It's 501-5140. Now I'm going to repeat all of it. I'm going to put it in the chat. I'm just going to make sure it's all correct. Okay, so it's in the chat. So for appointments, you need a referral from your doctor faxed to 404-501-7186. And if you want to call the office with questions, like if you forget how to make the appointment or whatever, or what the doctor needs to send, you can call 404-501-5140. Now I'm going to give you guys my email with just the stipulation that I'm not here every day, and sometimes it takes me a little bit of time. But if you have questions about like the content, like brief questions, I'm happy to respond to brief questions. If they're more complex, then you probably want to come in so I can evaluate you. But my email is my first name. You can see my name right here. It's TESSA.Elliott, ELLIOTT @emoryhealthcare.org. And I put that in the chat as well.
And I have cut and pasted all of this and I've got it in email and I can send it to you guys if you want it. Just let me know.
Yes, please.
Awesome. Well, I hope that's a good day. And thanks for inviting me to come talk with you. And
Tessa, thank you so much. You did a great job. You got a great response. I'm really happy to have you and hope you'll come back in person someday.
yeah, I
Thank you.
would be happy to.
Thank you,
All
Tessa.
right. Take care. I'm going to log off.
Thank you. Be safe, dear.
Thank you
Take
so
care.
much.
Thank you very much.
See you all in other classes soon. Bye-bye.
Thanks, Victoria.
You're
That was a
welcome,
great
Dawn.
idea.
See you soon.
Thank you.
You're welcome. Bye-bye.